Thyroid disease. Thyroid disease consists of a multitude of disorders affecting the production or secretion of thyroid hormones, resulting in an altered metabolic state. The clinical and biochemical syndromes resulting from too little or too much thyroid hormone production are called hypothyroidism and hyperthyroidism, respectively. Second physiology. A. Thyroid hormone regulation. 1. The thyroid gland synthesizes, stores, and secretes thyroxine, or triiodothyronine, D3 hormones that are important to growth, development, metabolic rate, as well as the maintenance of healthy, mature, central nervous and skeletal systems. 2. Thyroid hormone secretion and transport are controlled by thyroid-stimulating hormone, thyrotropin, TSH. TSH is released by the anterior pituitary gland that is triggered by thyrotropin-releasing hormone, THRT, secreted from the hypothalamus. A. Stimulation of the thyroid by TSH produces increased levels of thyroid hormone, circulating free T4 and free T3, which, in turn, signals the pituitary to stop releasing TSH negative feedback. B. Conversely, low blood levels of free hormone trigger pituitary release of TSH, which stimulates the thyroid to secrete T4 and T3 until free hormone levels return to normal. At this point, the pituitary gland ceases to release TSH, which completes the feedback loop, figure 47-1. C. This negative feedback mechanism attempts to maintain the level of circulating thyroid hormone within a narrow range. 3. The thyroid gland also secretes calcitonin, which plays a role in calcium homeostasis by reducing blood calcium ion concentration. Thyroid disease. Eric C. Nemec. 47-1. Thyroid hormone regulation loop. This carefully balanced hormone regulation system uses both positive, stimulating, and negative, inhibiting feedback to maintain homeostasis. Disruption of any of these elements can produce serious consequences, such as myxedema crisis, underavailability of thyroid hormone, or thyroid storm, overabundance of thyroid hormone. T3, triiodothyronine. T4, thyroxine, TRH, thyroid-releasing hormone, TSH, thyroid-stimulating hormone. Thyroid disease 955. B. Biosynthesis, figure 47-2-1. Essential to synthesis of thyroid hormones is dietary iodine, reduced to inorganic iodide, which the thyroid actively extracts from the plasma through iodide trapping, iodide pump. Some of this iodide is stored within the colloid. Some diffuses into the lumen of thyroid follicles. 2. Iodide is oxidized by thyroid peroxidase and bound to tyrosine residues within the thyroglobulin molecule in the colloid via a process called organification. A. The oxidation of inorganic iodide to iodine and incorporation into tyrosine residues occurs within thyroglobulin molecules in the colloid, forming monoiodotyrosine, MIT. B. Diodotyrosine, DIT, results from the iodization of MIT. C. The combination of two DIT molecules forms tetraiodothyronine, thyroxine, T4, and the combination of MIT with DIT forms triiodothyronine, T3. These reactions are also catalyzed by thyroid peroxidase. C. Hormone transport 1. After TSH stimulation of the thyroid gland, T4 and T3 are cleaved from thyroglobulin and released into the circulation. 2. When in the circulation, thyroid hormone is transported bound to several plasma proteins, a process that A. helps protect the hormone from premature metabolism and excretion, B. prolongs its half-life in the circulation. C. Allows the thyroid hormone to reach its site of action. 3. Most thyroid hormone is transported by thyroxine-binding globulin, TBG. Transthyretin, TBPA, thyroxine-binding prealbumin, and albumin also serve as carriers. 4. T4 and T3 are lipophilic molecules and cross the cell membrane easily. However, there are iodothyronine transporters that facilitate transportation. D. Hormone metabolism. 1. T4 is solely a product of the thyroid gland, whereas T3 is a product of both the thyroid as well as many other tissues. It is produced by deiodination of T4. 2. Peripheral conversion of T4 to T3 occurs in the pituitary gland, liver, and kidneys and accounts for about 80% of T3 generation. 3. Deiodination accounts for most thyroid hormone degradation. The major steps in this process are shown in Figure 47-3. 4. Deiodinated hormones are excreted in feces and urine. 5. Minor non-deiodination pathways of metabolism include conjugation with sulfate and glucuronide, deamination, and decarboxylation. E. Hormone function. 1. Although the effects of thyroid hormones are known, the basic mechanisms producing these effects elude precise definition. However, they seem to activate the messenger RNA, mRNA transcription process, and can promote protein synthesis or, in excessive amounts, protein catabolism. 2. Thyroid hormones affect the following. A. Growth and development by regulating long bone growth and affecting protein synthesis. B. Calorigenesis by increasing the rate of basal metabolism. C. Cardiovascular system by increasing the metabolic rate, which increases blood flow, cardiac output, and heart rate, may be related in part to an increased tissue sensitivity to catecholamines. D. The central nervous system, CNS, by increasing or diminishing cerebration. E. Musculature by causing a fine tremor. F. Sleep by inducing wakefulness with hyperthyroidism or somnolence with hypothyroidism. G. Lipid metabolism by stimulating lipid mobilization and degradation. F. Thyroid function studies, Table 47-1. 1. Serum thyrotropin, assay. This test is the most sensitive test for detecting the hypothyroid state because the hypothalamic pituitary axis compensates very quickly for even slight decreases in circulating free hormone by releasing more TSS. The TSH levels may be elevated even before low circulating levels of serum total T4 are detectable by diagnostic testing. 956, Chapter 47-2. F. Figure 47-2. Biosynthesis of thyroid hormones. The major products are thyroxine, T4, and triiodothyronine, T3. These are formed in the follicle cells of the thyroid gland by iodination of tyrosine residues. Monoiodotyrosine and diiodotyrosine residues are formed Phi-RST. These then react to form T3 and T4. Thyroid disease. 957. B. The early TSH assay used radioimmunoassay (RIA) methodology. The sensitivity of the assay has improved since, moving to the use of monoclonal antibodies in the late 1980s. Nomenclature established by the American Thyroid Association, ATA, has classified the improvement in sensitivity based on the lower limit of detection. The new classification follows a generational format, as shown in Table 47-3. C. The current, third generation, serum TSH level of detection 0.01 to 0.02 MUA uses monoclonal antibodies, referred to as immunoradiometric (IRMA) or immunometric (IMA) methodology, instead of the older RIA techniques, and demonstrates greater sensitivity in the detection of thyroid disease than older tests. D. This assay is usually used to diagnose thyroid disease and monitor patients receiving replacement therapy to control overtreatment. Overtreatment, NaCS 0.4 ml, may contribute to excessive bone demineralization, reduced bone density, electrocardiogram, ECG changes, atrial fibrillation, or elevation of liver function tests. Table 47-1 test results in thyroid disorders. Thyroid function test, hypothyroidism, hyperthyroidism. Serum resin triiodothyronine, 35%, 45%. Uptake, or T3, serum total thyroxine, TT4, 5 grams. Dalol, 12 grams stel. Serum total. Triiodothyronine, Tridothyronine 80 nanograms del, 180 nanograms cell. Free thyroxine index, IET, 555, 10.5. Serum thyrotropin, TT, Asaya, 4.5. U, or UE. In clinical practice, the third-generation test is commonly used with sensitivity to detect 0.01, 1.02. B fourth-generation assays detect 0.001, 1. Increased levels, decreased levels. Figure 47-3. Thyroxine metabolism. Major steps in the primary and alternative deiodination pathways. 958, Chapter 47-2. If E. The IMA technique is very sensitive. The fourth-generation IMA can detect TSH levels in the range of 0.001 to 0.002 μL. If the third-generation IMA assays may also detect subclinical thyroid disease, it is 0.1 to 0.45 μL. Treatment of subclinical hypothyroidism is controversial because there is insufficient evidence to indicate a benefit. G. TSH levels may also be influenced by psychiatric illness. Some studies of hospitalized patients have reported abnormally high or low TSH levels in otherwise euthyroid patients. Current findings in HIV-positive patients are uncertain. However, autoimmune thyroid disease appears to be more prevalent in these patients. H. Effects of drugs on the serum TSH are shown in tables 47-2 and 47-4. I. There is some controversy as to the appropriate upper limit of normal for serum TSH. Most laboratories use values of about 4.5 to 5 μUL. 2. Serum total thyroxine, DT4A. This test provides the most direct reflection of thyroid function by indicating hormone availability to tissues. It determines total, free and bound, T4 by RIA, which is sensitive and rapid. B. Virtually all, 99.97%, of serum T4 is bound to TBG, TBPA, or albumin. C. Changes in thyroid globulin concentration, particularly TBG, which increases during pregnancy, alter the total concentration of T4 and may produce a misleading high or low test result. D. However, these changes in TBG do not affect the concentration of free T4. Therefore, to clarify thyroid function, either protein binding, T3 uptake test, or free T4 must be measured. E. An elevated TT4 level indicates hyperthyroidism. A decreased TT4 level, hypothyroidism. However, the TT4 level in a euthyroid patient can be altered by other factors, such as pregnancy or febrile illnesses, which elevate the TT4, nephrotic syndrome or cirrhosis, which lower the TT4, and various drugs, table 47-2. F. Normal ranges vary among laboratories. A typical range is 4.6 to 11.2 mTGDL3. Serum total triiodothyronine, DT3A. This sensitive and highly specific test measures total free and bound T3 via RIA. B. T3 is less tightly bound to TBG and TBPA, but more tightly bound to albumin than T4. C. Serum T4 and T3 usually rise and fall together. However, hyperthyroidism commonly causes a disproportionate rise in T3, and the TT3 can rise before the TT4 level. Therefore, TT3 is useful for early detection or to rule out hyperthyroidism. Many of the symptoms associated with hyperthyroidism are the result of the elevated TT3. D. This test may not be diagnostically significant for hypothyroidism, in which TT3 levels may fall but stay within the normal range. The TT3 may be low in only 50% of patients with hypothyroidism. E. If there is an abnormality in binding proteins, this test can yield the same misleading results as the TT readings. Other factors affecting test results include pregnancy, which increases TT3 levels, malnutrition or hepatic or renal disease, which lower TT3 levels, or various drugs, Table 47-2. F. Normal ranges vary among laboratories. A typical range is 75 to 195 nanograms DL. 4. Resin triiodothyronine uptake, RT3U-A. This test clarifies whether abnormal T4 levels are the result of a thyroid disorder or to abnormalities in the binding proteins, because it evaluates the binding capacity of TBG. B. If an abnormal amount, high or low, of thyroid hormone is present in the blood, the RT3U results change in the same direction as the altered level, elevated in hyperthyroidism, decreased in hypothyroidism. C. However, if there is an underlying abnormality in binding proteins, the abnormal levels of TT4, TT3, or both, the RT3U results change in the opposite direction, decreasing as TBG increases, increasing as TBG decreases. D. Several drugs can cause spurious changes in the RT3U, Table 47-2. 5. Free thyroxine index, FDA. A. Free hormone represents only 0.03% of serum total T4. B. The FDI has the advantage that the clinician is given both a total T4 and a thyroid hormone binding ratio or index. D. By making it clear when the patient has a potential binding protein abnormality. TBRT3 and mean serum RT3U. Thyroid disease, 959. Table 47-2. Effects of drugs on thyroid function tests free. Resin, thyroxine. Drug, serum T4, T3 uptake, index. Serum T3, serum TSH, comment, p-aminosalicylic acid, NDD, a antithyroid effect, rarely, with long-term use. Aminoglutathamide, cytadrin, NED, NAQ, inhibits peripheral conversion of T4 to T3, anabolic steroids and androgens. 0. NED, decreased serum TBG, antithyroid drugs. 0. Or TS may increase if patient becomes propylthiouracil or hypothyroid, methimazole, asparaginase, L-SPAR, NDD, decreased serum TBG, barbiturates, C, NDD, NAD, stimulates T4. Metabolism. Calcium carbonated. NDD. NDD. 0. Subclinical signs of hypothyroidism. Separate time of ingestion of calcium and levothyroxine, ciprofloxacin. NAD. NAD. Clinical signs of hypothyroidism. Separate administration by 6. Contraceptives. Oral. 0. TBG usually increased corticosteroids. 0 or usual doses decrease TBG. High doses may increase TBG. Danazol, Danacream. 0 or decreased serum TBG. Estrogens and SERMs G. 0 increased serum TBG. Ethinomide, Tricator Snapchat. NDD, NDD, antithyroid effect. Fluorouracil, Adrucil. NE, 0. Patients. Clinically, euthyroid, TBG increased. Heparin, IVA, H, 0 or A0. NAD, FTI, is increased with some measures. Hypoglycemics, sulfonylureas. 0. NTD, iodides, inorganic. 0. NTD, iodides, organic. 0. NT. Levodopa and levodopa. 0. J. Carbidopa, Simet, Parcopa. Levothyroxine, Levothyroid. SKL, or 0 or KL, 0 or KL or Xeroc, Ale or Xeroc. Levoxyl, Synthroid, Unithroid. Liothyronine, Cytomel, K0 or K or K-Ale, Xeroc. Liotrix, Thyroller, Xeroc or S. Xeroc, L, Xeroc. Continued on next page. 960, chapter 47-2. F, table 47-2. Continued. Free, resin, thyroxine, drug, serum T4, T3 uptake, index, serum T3, serum T. Comment, lithium carbonate, escalith, 0 or lithobid, methadone, belafine. S, 0, increased serum TBG, mitotane, lysodrin, 0, NED, nitroprusside, nitropress, ND, NAD, clinical, hypothyroidism, oxyphenbutazone, and 0 A, may compete with T4. For TBG binding, rarely, phenylbutazone, butazolidine. Overt hypothyroidism and goiter may occur. Perfenazine, trilofan. 0. Phenytoin dilantin. 0 or S. 0 stimulates T4 metabolism and may compete with T4 for TBG binding. Propranolol indrol, 0 or M. Xeron, NADO, 0, raloxifene-gavista. East serum TBG. Resorcinol, excessive topical use. salicylates, large doses, S0, compete with T4 for TBG binding, tamoxifen, 0, increased serum TBG, effect deduced, not based on reported clinical evidence, beta from Ray, P. Farrar, J. Beckett, G. and others' assessment of thyroid status in elderly people, BR, Med, J. 1993, 307, Thyroid 97, 93. C patients requiring thyroid replacement therapy have decreased serum thyroxine when barbiturates are given. Data from Singh N. Singh PN, Hirschman JM. Effect of calcium carbonate on the absorption of levothyroxine. JAMA 2283-21, 1822, 2800, 2000, Harboic, Frosk, et al. Ciprofloxacin interacts with thyroid replacement therapy. Bromage, 2005, 337,498, 1002. It may increase slightly but usually remains in the normal range. Data from Sirajas, Guptank. But for radioimmunoassays is probably not affected. Free thyroxine measured by dialysis may be increased. It may occasionally decrease serum T4 and increase resin T3 uptake, J-slight decrease in euthyroid patients, but in long-standing hypothyroid patients, levodopa considerably decreases the elevated TSH. Kin patient on adequate doses for thyroid replacement, increased T4, FDI, and T tend to return to normal after several months of therapy with levothyroxine. After liothyronine, T3 may be elevated 2 HRs after a dose and depressed. 2004 HRS after a dose increased. T4 levels are reported in one study, but not in others. With short-term propranolol in hyperthyroid patients, in euthyroid patients, the decreased serum T3 returns to normal with continued propranolol therapy. Free thyroxine index may increase slightly, but usually remains in the normal range. Q data from Batcher L, Tang XC Singh BN, and others thyroid function abnormalities during amiodarone therapy for persistent atrial fibrillation, AM, J. Med, 2007, 120, 880, 885. FDI, free thyroxine index. IV, intravenous, NED, no. Data. S, slight. Effect, Snapchat, subcutaneous. SERMs, selective estrogen receptor modulators. T3, triiodothyronine. T4, thyroxine. TBG, thyroxine binding globulin. TSH, thyroid stimulating hormone. 0, no. Effect, no. Increased, decreased. Thyroid disease 961. FDI is not a separate test, but rather an estimation of the free T4 level through a mathematical interpretation of the relationship between RT3U and serum T4 levels. FTI-TT4 RT through amine serum RT through U. D. FTI values are elevated in hyperthyroidism when TBG is low and decreased in hypothyroidism when TBG is elevated. E. Effects of drugs on FTI are shown in Table 47-2. G. Strategies and cost considerations for testing one. The AT recommends a free thyroxine, FT4, and a sensitive TSH assay as the primary laboratory test for diagnosing thyroid disease, Figure 47-4. 2. Thyroid disease screening for the otherwise generally healthy population has been shown to not be cost-effective based on the rate of detection and cost associated with massive screening. However, with increased use and improvements in technology, costs have been falling, Figure 47-5. 3. Screening of asymptomatic individuals is controversial, and recommendations from major medical groups have been conflicting. The most appropriate target population for screening includes A. Women older than 60 years and others at high risk for thyroid dysfunction, history of autoimmune disease or type 1 diabetes. B. Family history of thyroid disease. C. Patients with clinical symptoms of hypothyroidism, hyperthyroidism. D. Pregnant women or those hoping to become pregnant. 4. The sensitive TSH assay is useful in detecting patients at risk of receiving an excess amount of thyroxine as replacement therapy. Third, hypothyroidism is the inability of the thyroid gland to supply sufficient thyroid hormone. There are varying degrees of hypothyroidism from mild, clinically insignificant forms to the life-threatening extreme, myxedema coma. E. Classification 1. Primary hypothyroidism, 90% of hypothyroidism cases. A. Gland destruction or dysfunction caused by disease or medical therapies, for example, radiation. Surgical procedures. B. Failure of the gland to develop or congenital incompetence, that is, cretinism. 2. Secondary hypothyroidism. A. Result of a pituitary disorder that inhibits TSH secretion. The thyroid gland is normal but lacks appropriate stimulation by TSH. 3. Tertiary hypothyroidism. A. Refers to a condition in which the pituitary thyroid axis is intact, but the hypothalamus lacks the ability to secrete TRH to stimulate the pituitary. 4. Subclinical hypothyroidism. A. Refers to patients without clinical symptoms, a normal FT4, and elevated TSH levels. Currently, there is insufficient evidence to support treatment because consequences of non-treatment are minimal. However, pregnant women with subclinical hypothyroidism may benefit from T4 replacement. Table 47-3 serum thyroid stimulating hormone. Assay nomenclature. Generation lower level of detection. First, RIA method 1, 2 MIU, second 0.1, 0.2 MIU, third 0.01, 0.02 MIU, 0.001, 0.002 MIU. RIA radioimmunoassay. 962, Chapter 47, third. Table 47-4. Medications influencing thyroid-stimulating hormone, PO, levels, effect, and other. Potential clinical. Thyroid function. Agent. Mechanisms. Thyroid effect. Effect on tests. Comments. Amiodarone. Iodine effects. C. Clinical or hypothyroidism is usually increased total T4, the large iodine load with the iodine below. Subclinical, detected during the Phi RST 3 months, levels, administration. of amiodarone. Hypothyroidism, after starting therapy, is the primary contributor. 2. Subclinical. Continue to detect the drug interaction regions. Hyperthyroidism. Patients at 6 months, where patients have adequate, infrequently, overt hypothyroidism. Intake of iodine in their diet have 10 UDML has been associated with higher rates been observed of hypothyroidism biochemical 6 months mild elevations changes in thyroid function noted dosage 4.5 by 10 UVML have in a majority of patients on been observed at therapy requiring frequent 12 months subclinical monitoring hyperthyroidism ERTISH 0.35 UBML has been observed occasionally. Direct inhibition of increased free T4 to T3 conversion levels. Direct toxic effects, increased reverse T3 on thyroid levels, induction of thyroid hyperthyroidism, decreased total and autoimmunity, free T3 calcium, adsorption of subclinical elevation, decrease free T4 and carbonate, levothyroxine, 2. Hypothyroidism, total T4 calcium in acid environment, ciprofloxacin, decreases absorption. Hypothyroidism, elevation, decreased thyroid, clinical hypothyroidism of levothyroxine, hormone levels detected, corticosteroids, central suppression, minimal or none suppression, usually within compensatory mechanisms of TSH release, normal range, lead to normalization of, although total, T4 TSH levels with chronic, free T4, T3, reduced exposure and reverse T3, increased from baseline. Thyroid disease 963. Continued on next page. Reduction of thyroid. Iodine uptake inhibition of T4 to T3. Conversion reduction of thyroid binding globulin levels, dopamine and central suppression, minimal or none suppression, normal or decreased, prolonged use of dopamine in high dopamine of TSH release, hormone levels, doses may potentiate the low agonists, thyroxine state of critical illness, dopamine, release of central, minimal or none, elevation, usually normal, affects not well, characterized, antagonist TSC inhibition, iodine, inhibition of iodine, clinical, or elevation, decreased thyroid. Clinical, hypothyroidism, most, uptake and subclinical, hormone levels, common in those with underlying organification, hypothyroidism, organification, defects such as autoimmune thyroiditis or previous radioiodine therapy. Iodine-induced hyperthyroidism is generally confined to those with iodine deficiency or autoimmune thyroid disease. Impairment of thyroid, hormone inhibition of T4 to T3, hyperthyroidism, suppression, elevated thyroid, conversion, hormone levels, induction of thyroid autoimmunity. Interferon, unclear, likely, hypothyroidism, elevation, decreased thyroid. No apparent direct NfL on, owing to silent thyroiditis, hormone levels, TSH secretion, per treatment. Immunomodulating, Graves' disease, detectable, antimicrosomal properties and antibodies may represent a risk. Stimulation of factor 4, interferon-induced. Autoimmunity, thyroid disease, hyperthyroidism, suppression, increased thyroid, with or without hormone levels. Autoantibodies, 964, Chapter 47, the third. A. Lithium salts. Inhibition of clinical or elevation, normal or decreased. Some sources recommend thyroid, iodothyronine, subclinical, thyroid hormone, function testing at 6 month. Biosynthesis, hypothyroidism, levels, intervals while on therapy, reduction of thyroid, iodine concentration, suppression of thyroid hormone release, induction of thyroid autoimmunity. Radiographic, iodine effects, minimal or none, elevation, normal or decreased, alterations, are maximal. 3 otter days. Contrast, see iodine above. Thyroid hormone, after administration, and media levels persist for up to 2 weeks. Direct inhibition of elevation of reverse, T4 to T3, T3 levels, conversion, raloxifene. Malabsorption, hypothyroidism, elevation, decreased thyroid, clinical, hypothyroidism, mechanism, hormone levels, detected, unknown, somatostatin, central, suppression, normal or none. Suppression, usually normal, affects not well, and analogs of TSH release, characterized T3, triiodothyronine, T4, thyroxine, table 47-4, continued. Effect on other. Potential clinical, thyroid function, agent, mechanisms, thyroid effect on TSH. Tests, comments, thyroid disease 965, figure 47-4. Algorithm for using a sensitive thyroid stimulating hormone, assay as a single test of thyroid function. The algorithm assumes a clinically intact hypothalamic pituitary axis, absence of medications known to interfere TSH or other thyroid indices, and generally good physical and psychiatric health. The TSH assay should meet the American Thyroid Association criteria for a sensitive assay and/or have a known functional sensitivity limit at the second generation, 0.1 μL level or greater. Close follow-up, clinical observation for signs and symptoms of hyperthyroidism or hypothyroidism, and repeated TSH determinations at intervals of 6 to 12 months. T3, triiodothyronine, T4, thyroxine, TSH, normal, low or normal subnormal, high normal, T3 free, T3, high normal, subclinical hyperthyroidism, close follow-up. Low normal, subclinical hypothyroidism, antithyroid antibodies. Consider treatment versus close follow-up based on clinical manifestations, presence and titer of antithyroid antibodies, degree of TSH elevation. History of radioiodine, treatment, replacement, therapy, close follow-up, free T4, elevated, euthyroid, no additional, testing, free T4, low, 0.1 μL, subnormal, 0.1 μL, and below lower limit of normal. Consider advanced Forasay generation TSH testing, suppression suggestive of hyperthyroidism. Repeat TSH testing GIF, clinically euthyroid. Hyperthyroidism. Treatment. B. Causes 1. Hashimoto thyroiditis, a chronic lymphocytic thyroiditis that is considered to be an autoimmune disorder. 2. Treatment of hyperthyroidism, such as radioactive iodine therapy, subtotal thyroidectomy, or administration of antithyroid agents. 3. Surgical excision of thyroid gland. 4. Goiter, enlargement of the thyroid gland. A. Endemic goiter results from inadequate intake of dietary iodine. This is common in regions with iodine-depleted soil and in areas of endemic malnutrition. B. Sporadic goiter can follow ingestion of certain drugs or foods containing progoitrin, L-5-vinyl-2-thioxazolidone, which is inactive and converted by hydrolysis to goitrin. 1. Goitrins inhibit oxidation of iodine to iodide and prevent iodide from binding to thyroglobulin, thereby decreasing thyroid hormone production. 2. Progoitrin has been isolated in cabbage, kale, peanuts, Brussels sprouts, mustard, rutabaga, kohlrabi, spinach, cauliflower, and horseradish. 3. Goitrogenic drugs include propylthiouracil, 32, iodides, amiodarone, and lithium. 966, Chapter 40, 7 the 3rd. B. Figure 47-5. Algorithm for the use of sensitive thyroid-stimulating hormone. Testing in patients with non-thyroidal illness, NTI. The TSA should meet the American Thyroid Association criteria for a sensitive assay and/or have a known functional sensitivity limit at the second generation, 0.1 μL level or greater. Medications known to alter TSH levels, that is, corticosteroids, dopamine, must be considered when interpreting results. TSH, low-high, low with subnormal, normal, elevated. Free T4, normal. Free T4, free T4. Low, normal, high, low, normal, high. Possible effect of NTI, hypothalamic, pituitary failure. Possible effect of NTI, subclinical hyperthyroidism. Recovery phase of NTI, subclinical hypothyroidism. Probable hyperthyroidism. Probable hypothyroidism. Possible effect of NTI, hypothalamic, pituitary failure. Likely euthyroid. Possible effect of NTI. Possible effect of acute psychiatric illness. C. Less common causes include acute, usually traumatic, and subacute thyroiditis, nodules, nodular goiter, and thyroid cancer. 5. Amiodarone's intrinsic drug effects as well as its high iodine content can cause thyroid dysfunction, both hypothyroidism and hyperthyroidism. E. It causes decreased T3 production, T3 receptor binding, and direct toxic effect on thyroid follicular cells. B. Amiodarone's iodine content has a direct toxic effect on the thyroid and can cause both hypothyroidism and hyperthyroidism based on other underlying disease states. C. Signs and symptoms. 1. Early clinical features tend to be somewhat vague: lethargy, fatigue, depression, forgetfulness, sensitivity to cold, unexplained weight gain, and constipation. 2. Progressively, the characteristic features of myxedema emerge: dry, flaky, inelastic skin, coarse hair, slowed speech and thought, hoarseness. Hands and feet, eyelid droop, hearing loss, menorrhagia, decreased libido, and slow return of deep tendon reflexes, especially in the Achilles tendon. If untreated, myxedema coma will develop. D. Laboratory findings, Table 47-1E. Treatment goal is replacement therapy to mimic normal physiologic levels and alleviate signs, symptoms, and biochemical abnormalities. Table 47-5. F. Therapeutic agents. 1. Desiccated thyroid preparations. A. At one time, the agent of choice, desiccated thyroid, armor thyroid, Westroid, has fallen out of favor since standardized synthetic levothyroxine preparations have become available. B. Desiccated thyroid preparations are not considered bioequivalent. They have evidenced varying amounts of active substances. Although they met established United States Pharmacopoeia (USP) criteria for iodine content, variation in hormonal content and activity was noted. The content assay, while specific for iodine, was unable to specify the ratio of T3 to T4, and this ratio varies with the animal source. Porcine gland preparations are most commonly used and have a higher T3 to T4 ratio than those from ovine and bovine sources. 2. Fixed ratio Lyotrix, Thyrolar preparations. In an effort to standardize the T3 to T4 ratio, substances that mimic glandular content were developed. However, the T3 component proved unnecessary because T4 is metabolized to T3, and even disadvantageous because of T3-induced adverse effects, for example, tremor, headache, palpitations, diarrhea. Thyroid disease 967. 3. Levothyroxine A. Predictable results of the synthetic T4 preparation and lack of T3-induced side effects have made levothyroxine, Levothyroid, Synthroid, and Levoxyl the agent of choice. B. Levothyroxine preparations are generally considered bioequivalent despite significant controversy. However, when switching formulations, it is recommended to monitor the patient closely because there may be some individual patient variability among formulations. Figure 47-6. C. The average adult maintenance dose is 75 to 150 mcg day. The dose range has been shown to be 1.5 to 1.7 mcg day, or an average of 1.6 mcg a day for otherwise healthy adults. Levothyroxine should be administered preferably on an empty stomach in the morning, before breakfast. D. Elderly or chronically ill patients require an average dose of 50 to 100 mcg day, which is 25 to 50 mcg day, less than otherwise healthy adults of the same height and weight. E. Atheriotic pregnant patients may require a 25% to 50% increase in levothyroxine dosage when pregnancy is confirmed. FD, a pregnancy category A. Pre-pregnancy dosage can be reinstated immediately following delivery. F. Thyroxine levels usually return to normal within a few weeks. Clinical improvement begins in 2 weeks with full resolution of signs and symptoms of hypothyroidism by 3 to 6 months of therapy. G. TSH levels begin to decrease after starting thyroid replacement. TSH remains elevated for some time after T4 levels return to normal. Generally, TSH levels return to normal after a minimum of 6 to 8 weeks, but may continue to fall over 6 to 12 months. Figure 47-6. 4. Liothyronine A. Liothyronine, cytomel, is the L isomer of T3B. Average adult maintenance is 25 to 75 mcg day C. Liothyronine is generally not recommended for treating hypothyroidism. However, It may be useful treating patients with persistent clinical symptoms on levothyroxine. Assessment of this therapy requires measurement of serum T3 and TSG, since liothyronine will not affect serum T4. Table 47-5 Thyroid Replacement Preparations. Preparation, trade names, advantage, disadvantage, comments, source. Desiccated thyroid low cost. Some preparations contains T3, some porcine, bovine, or thyroid USP, have unpredictable brands are ovine thyroid glands thyroid strong. Results, inconsistent standardized by Armor Thyroid, T3-T4, ratio T3 increases iodine content of thyroid, SPT. Adverse effects liothyronine predictable results, lacks T4 usually reserved for synthetic. Cytomel. Useful for myxedema crisis. Liotrix. Thyroller. Standardized T3 increases adverse fixed T3-D4 ratio of synthetic. Formulation effects. Expensive 1-4. Metabolism of T4 to T3 renders T3 component unnecessary. Levothyroxine predictable results. Expensive agent of choice. Does synthetic levothyroid intravenous not contain T3? All synthroid, levoxyl, preparations may unithroid, available be interchangeable. Iodine content in T3, D4, ratio vary with species. Generic formulations manufactured by pharmaceuticals basics for Geneva generics and Rugby have been shown to be bioequivalent to synthroid and levoxyl. T3, triiodothyronine. T4, thyroxine. USP, United States Pharmacopoeia. From Dong B.J., Hawk W.W., Gambertoglio J.G., et al. Bioequivalence of generic and brand name levothyroxine products in the treatment of hypothyroidism. JAMA, 1997, 277-15, Welvo 5, Vol 290, 968, Chapter 47, the 3rd. G. Precautions and monitoring effects 1. Adult patients with a history of cardiac disease and elderly patients should begin therapy with lower doses, for example, 25 mcg day of levothyroxine. After 2 to 4 weeks, the dose should be increased gradually 12.5 to 25 mcg to an individually adjusted maintenance dose, usually 100 mcg daily. 2. Patients should be observed on initiation of therapy for possible cardiac complications, such as angina, palpitations, or arrhythmias. 3. Serum thyroid levels should be monitored, particularly T4, sensitive TSH and RT3U levels, and the FTI. Serum thyroxine tests may remain elevated during the first few months of treatment, even with the presence of clinical symptoms. Serum thyroxine tests do not predict the clinical state. Testing is unnecessary unless non-compliance is suspected. 4. It is recommended to monitor the sensitive TSH test 2 to 6 months after the last dose change. However, this test continues to change for up to 1 year. Testing early may result in overtreatment. Refer to Figure 47-6 for the management of patients on levothyroxine therapy. 5. Levothyroxine administration, particularly long-term therapy, can induce thyrotoxicosis. T4 levels can rise even though the dosage remains unchanged. Monitor for clinical signs of thyroid disease. 6. Accelerated bone loss has been associated with overtreatment. Patients receiving replacement therapy with low TSH values may have lower bone mineral density because excess hormone accelerates the rate of remodeling, rate of resorption, rate of formation, and may contribute to an increased incidence of non-traumatic fracture. 7. Drug interactions. Cholestyramine, questrin, and cholestipol, cholestid, Bile acid sequestrants can contribute to a decrease in thyroxine bioavailability when administered concomitantly. Bile acid sequestrants should be administered at least 6 HRS after oral thyroxine to reduce the potential for this clinically significant drug interaction. Figure 47-6. Algorithm for management of patients on levothyroxine therapy. TSH, thyroid stimulating hormone. TSH level after minimum of 6 to 8 weeks of therapy. Initiation of levothyroxine therapy. Normal elevated, normal abnormal. Annual TST determination. Dose adjustment. Subnormal or suppressed. Assess compliance. And symptoms. Consider thyroid hormone measurement. TSH level following 6 months of therapy. Dose reduction. TS elevation mild. 20 μ. Absence of symptoms. Normal hormone levels. TSH elevation significant. 20 μL. Symptoms. Consistent with hypothyroidism. Low thyroid hormone levels. Dose escalation. Thyroid disease 969. B. Calcium carbonate, OS-Cal, TUMS, can reduce thyroxine bioavailability by adsorption in an acid environment. These should be administered separately to avoid interaction. C. Estrogens, estrase, premarin, and selective estrogen receptor modulators, SERMs, tamoxifen, Nolvadex, or raloxifene, Evista, may contribute to lower levels of FT4 and elevated TSH levels, requiring an increase in levothyroxine dose. D. Raloxifene has been shown to cause malabsorption of levothyroxine when co-administered, resulting in hypothyroidism. Absorption studies demonstrated that separating administration times by 12 HRS for the two medications prevents the interaction. E. Ciprofloxacin, or Cipro, has been reported to interact with levothyroxine when given together, resulting in elevated TSH and reduced FT4 and FT3 levels. Administration of the drugs separately, with a 6 HR interval, resulted in rapid normalization of the thyroid function tests. 8. FD, a black box warning. Do not use thyroid hormones, including levothyroxine, either alone or with other therapeutic agents, for the treatment of obesity or for weight loss. They are ineffective for weight reduction in euthyroid patients and may produce serious or even life-threatening manifestations of toxicity, particularly when given in association with sympathomimetic amines such as those used for their anorectic effects. 9. Approximate oral dose equivalency. Levothyroxine 100 mcg, liothyronine 25 mcg, Thyroller. 1 grain desiccated thyroid, 1 grain H. Myxedema coma is defined as severe hypothyroidism leading to decreased mental status, hypothermia, and other symptoms related to slowing of function in multiple organs. It is a life-threatening complication with a high mortality rate. 1. It is most common in elderly patients with pre-existing, although usually undiagnosed, hypothyroidism. 2. Precipitating factors include alcohol, sedative hypnotic, or narcotic use, overuse of antithyroid agents, abrupt discontinuation of thyroid hormone therapy, infection, exposure to cold temperatures, and iatrogenic insult owing to radiation therapy or thyroid surgery. 3. The patient usually declines from profound lethargy to coma, hypothermia, and a significant decrease in respiratory rate, potentially leading to respiratory failure as the crisis progresses. Hypometabolism produces a fluid and electrolyte imbalance that leads to fluid retention and hyponatremia. Cardiac effects include decreased heart rate and contractility, decreasing cardiac output. 4. Treatment consists of rapid restoration of T3 and T4 levels to normal. A loading dose of levothyroxine 300 to 500 mcg is given as an intravenous bolus followed by a daily dose of 1.6 mcg/kg thereafter. Liothyronine may be given simultaneously as a dose of 5 to 20 mcg, followed by 2.5 to 10 mcg given orally every 8 HRS. B. Treatment is continued until improvement is noted. Then liothyronine is discontinued, and levothyroxine is changed to the oral preparation. A maintenance dose is then determined. See the third. F. Bre. IVAR. Hyperthyroidism is the overabundance of thyroid hormone. Thyrotoxicosis is the general term applied to overactivity of the thyroid gland. Graves' disease, diffuse toxic goiter 1. The most common form of hyperthyroidism. Graves' disease occurs primarily, but not exclusively, in young women. 2. The basis of this disease is an autoimmune disorder in which antibodies, TSR-AB, bind to and activate TSH receptors, resulting in the overproduction of thyroid hormone. TSR-AB are termed long-acting thyroid stimulators, LATs, because their duration of action extends beyond that of TSH, as TSH is only mimicked, not overabundant. Neither testing for TSH nor attempts to influence it are productive. B. Antibody titers often are elevated in patients with Graves' disease. 3. Signs and symptoms characteristic of Graves' disease include A. Diffusely enlarged non-tender goiter. B. Nervousness, irritability, anxiety, and insomnia. C. Heat intolerance and profuse sweating. D. Weight loss despite increased appetite. E. Tremor and muscle weakness. F. Palpitations and tachycardia. 970, Chapter 47-4. G. Exophthalmos, stare, and lid lag, slow upper lid closing. H. Diarrhea. I. Thrill or brood over the thyroid. J. Periorbital edema. B. Plummer disease, toxic nodular goiter. 1. This form of thyrotoxicosis is less common than Graves' disease. Its underlying cause remains unknown, but its incidence is highest in patients 50 years of age, and it arises usually from a long-standing non-toxic goiter. 2. The thyrotoxicosis is a result of one or more adenomatous nodules autonomously secreting excessive thyroid hormone, which suppresses the rest of the gland. Scanning confirms the diagnosis if it indicates that activity and iodine uptake are confined to the nodular mass, unless TSH is introduced. 3. Signs and symptoms are essentially the same as for Graves' disease, except that one or more nodular masses are found, rather than diffuse glandular enlargement, and ophthalmopathy is usually absent. Cardiac abnormalities, for example, congestive heart failure, tachyarrhythmias, are commonly seen with Plummer disease. C. Less common forms of hyperthyroidism. 1. Jod-Basedow phenomenon is an overproduction of thyroid hormone following a sudden, large increase in iodine ingestion through either a sudden reversal of an iodine-deficient diet or the introduction of iodide or iodine in contrast agents or drugs, for example, the antiarrhythmic agent amiodarone. 2. Factitious hyperthyroidism occurs with abusive ingestion of thyroid replacement agents, usually in a misguided effort to lose weight. Diagnosis is aided by the absence of glandular swelling and of exophthalmos, and the lack of autoimmune activity found in Graves' disease. 3. Subclinical hyperthyroidism refers to patients without clinical symptoms, a normal FT4 and FT3 and TSH levels below the lower limits of normal, 0.4 μl. Currently, There is insufficient evidence to support treatment because consequences of non-treatment are minimal. D. Laboratory findings. Table 47-1E. Treatment goal. Symptomatic relief is provided until definitive treatment can be effected. F. Therapeutic agents. 1. Antithyroid agents. Thiamidis. PTU and methimazole, tapazole A. These agents may help attain remission through direct interference with thyroid hormone synthesis. Both agents inhibit iodide oxidation and iodothioacetyl coupling. In addition, PTU, but not methimazole, diminishes peripheral deiodination of T4 to T3. B. Therapeutic uses of these drugs include 1. Definitive treatment in which remission is achieved. 2. Adjunctive therapy with radioactive iodine until the radiation takes effect. Preoperative preparation to establish and maintain a euthyroid state until definitive surgery can be performed. C. Dosages. 1 propylthiouracil, all for adults. The initial dose is 300 to 450 milligrams day in 3 divided doses, that is, 100 to 150 milligrams every 8 HRS. Adult patients with severe disease may require as much as 600 to 900 milligrams day initially. B. The initial dose is continued for about 2 months, then a maintenance dose of 100 to 150 milligrams a day is given, as a single dose or divided into 2 doses. C. Maintenance therapy is continued for approximately 1 year, then gradually discontinued over 1 to 2 months while the patient is monitored for signs of recurrent hyperthyroidism. The patient may remain in remission for several years. A recurrent episode of hyperthyroidism is most likely to occur within 3 to 6 months of drug discontinuation. D. If hyperthyroidism recurs after drug therapy is stopped, the agent should be restarted, and alternative therapy should be considered, for example, thyroid gland ablation or removal. E. FD. A black box warning. Liver injury and acute liver failure, in some cases are fatal, have been reported in patients treated with PTU. If a medication guide must be dispensed with this product. Thyroid disease 971. Methimazole, tapazole, MA. The initial dose range is 15 to 60 milligrams a day in 3 divided doses, depending on disease severity. After 2 months of therapy, a maintenance dose of 5 to 30 milligrams a day is initiated. B. Maintenance therapy is continued for approximately 1 year, at which time the drug is gradually discontinued, usually over 1 to 2 months. C. MMI is generally preferred because of its longer duration of action, more rapid efficacy, and lower incidence of side effects. However, PTU may be the treatment of choice when therapy is indicated during or just prior to the first trimester of pregnancy due to risk of fetal abnormalities with MMI. MMI may be resumed during the second trimester. D. Precautions and monitoring effects. 1. Serum thyroid levels and the FTI should be monitored for a return to normal. An elevated T3 may indicate inadequate treatment, whereas an elevated TSH may indicate excessive antithyroid treatment. 2. Goiter size should decrease with reduced hormone output. 3. The adverse effects are similar for the 2 agents. The most bothersome are dermatologic reactions, for example, rash, urticaria, pruritus, hair loss, skin pigmentation. Others include headache, drowsiness, paresthesia, nausea, vomiting, vertigo, neuritis, loss of taste, arthralgia, and myalgia. B. Severe adverse effects are granulocytosis, granulocytopenia, thrombocytopenia, drug fever, hepatitis, and hypoprothrombonemia occur less frequently. Patients receiving methimazole who are 40 years old and are receiving doses above 40 milligrams a day are at increased risk of developing agranulocytosis. Patients receiving PTU who are 40 years old are at increased risk of developing agranulocytosis, but no dose association has been established. 2. Radioactive iodine, action. The thyroid gland picks up the radioactive element iodine 131I, as it would regular iodine. The radioactivity subsequently destroys some of the cells that would otherwise concentrate iodine and produce T4, thus decreasing thyroid hormone production. B. Advantages: 1. High cure rate, almost 100% for patients with Graves' disease, and only slightly less for patients with Plummer disease. 2. Avoid surgical risks, such as adverse reaction to anesthetics, hypoparathyroidism, nerve palsy, bleeding, and hoarseness. 3. Less expensive, avoids cost of hospitalization. C. Disadvantages: 1. Risk of delayed hypothyroidism. 2. Slight, though undocumented, risk of genetic damage. 3. Multiple doses, which may be required, may delay therapeutic efficacy for a long period, many months or a year. D. Usual dosage is 4 to 10 mcI administered orally. Toxic nodular goiter and other special situations will require the use of larger doses. E. Precautions and monitoring effects. Radioiodine is not typically used in patients younger than 30 years old, especially women, because effects on future offspring are not known. 2. Response to 131I is difficult to gauge, and patients must be monitored early for recurrence of hyperthyroidism, and later for hypothyroidism, which may develop even 20 years or more after therapy. 3. Adrenergic blocking agents. A. Propranolol, Indrel, usually dosed 20 to 40 mg 4 times daily, reduces some off-the-thyrotoxic manifestations, for example, tachycardia, sweating, severe tremor, nervousness of hyperthyroidism. B. In addition to providing symptomatic relief, propranolol at high doses, 160 milligrams a day, inhibit the peripheral conversion of T4 to T3. C. Blockers are primary adjunctive therapy to RI. 972, Chapter 47, 4. F. 4. Subtotal thyroidectomy. Partial removal of the thyroid gland may be indicated if drug therapy fails or radioactive iodine is undesirable or contraindicated. This is a difficult procedure, but the success rate is high and the cure is rapid. Risks include those mentioned in IV. F. 2. Precipitating thyroid storm, C4G2, and permanent postoperative hypothyroidism. The risk of inducing thyroid storm can be minimized by obtaining a euthyroid state through use of antithyroid agents, C4F, or propranolol, C4F3. G. Complications. 1. Hypothyroidism may occur iatrogenically, or, it has been proposed, as a natural sequel to Graves' disease. 2. Thyroid storm, thyrotoxic crisis, is a sudden exacerbation of hyperthyroidism caused by rapid release, leakage of thyroid hormone. It is invariably fatal if not treated rapidly. In this crisis, unchecked hypermetabolism leads ultimately to dehydration, shock, and death. A. Precipitating factors include thyroid trauma or surgery, RI therapy, infection, severe emotional stress, and sudden discontinuation of antithyroid therapy. B. characterized by a severe hyperpyrexia, tachycardia, agitation, delirium, psychosis, stupor, or coma C. Treatment is similar to that of uncomplicated hyperthyroidism, however. The doses are higher and given more frequently. Thiamide selection recommendations vary. PTU in doses of 800 to 1,200 milligrams a day, given as 200 to 300 milligrams every 4 to 6 HRs, may provide additional benefits over MMI as it prevents peripheral deadenation of T4 to T3. However, MMI 20 to 25 milligrams every 6 HRS has a longer duration of action. 2. Propranolol in doses of 60 to 80 milligrams every 4 HRS or 1 to 3 milligrams intravenously every 4 to 6 HRs should be administered unless blockade is contraindicated, for example, if the patient has T. 3. Potassium iodide, Lugol solution, SK Lugol solution, 10 drops 3 times daily, or SSK, 5 drops every 6 HRs, can be given after PTU to block thyroid hormone release. 4. Other supportive therapy includes rehydration, cooling, antibiotics, rest, and sedation. Study questions. Directions for questions 1-16. Each of the questions, statements, or incomplete statements in this section can be correctly answered or completed by one of the suggested answers or phrases. Choose the best answer. 1. What is the correct formula to use for calculating the FTI? A. T4 RT3 mean serum RT3U. B. T3 T3 mean serum RT3U. C. T3 RT3U in serum RT3U. D. T4 RT3U mean serum RT3U. E3 RT3U mean serum RT3U. 2. What is the necessary precursor besides dietary iodine required for thyroxine biosynthesis? A. T3, B. threonine, C. tyrosine, B. TC, D. TBG. 3. All of the following conditions are causes of hyperthyroidism except A. Graves' disease, B. Hashimoto thyroiditis, toxic multinodular goiter, D. triiodothyronine toxicosis, E. Plummer disease. 4. Which of the following preparations is used to attain remission of thyrotoxicosis? A. Propranolol, B. Liotrix, C. Levothyroxine, D. TTU, E. Desiccated thyroid. Thyroid D3. The thyroid gland normally secretes which of the following substances into the serum? D. TTTC, DIT, D. Thyroglobulin, or 6. All of the following conditions are causes of hypothyroidism except A. Endemic goiter, B. Surgical excision, Hashimoto thyroiditis, D. Goitrin-induced iodine deficiency, E. Graves' disease. 7. Common tests to monitor patients receiving replacement therapy for hypothyroidism include all of the following except A. TS stimulation test, B. Serum TSH assay, C. FTI, D. RT3U, ETT4. 8. The FTI allows the clinician to evaluate all the following except Aloe, TT4, BT-BY, C. Estimated free T4, D. Exact free T4, ACE D3U. 9. The inhibition of pituitary thyrotropin secretion is controlled by which of the following? A. Free T4, REV2RH, C. FTI, reverse, triiodothyronine, RT3, ET4. 10. Which of the following agents has been shown to interact with oral T4 replacement therapy? A. PTU, B. Cholestyramine, C. Thyrotropin, D. Levothyroxine, A. Lovastatin. 11. What laboratory tests are currently recommended by the ATA to diagnose thyroid disease? A. RT3U and TT4, VTH and FTI, ECT4 and sensitive TSH-assay, D-free T4 and sensitive TSH-assay, WAR and 3T4 and RT3U. 12. Which of the following patient populations should not routinely be screened for thyroid disease? A. Pregnant women, B. Patients with type I diabetes, C. Patients with a family history of thyroid disease, D. College students, E. Women 60 years old. 13. What is the average replacement dose of levothyroxine for an otherwise healthy adult? A. 25 to 50 mcg day, B. 50 to 100 mcg, C. 75 to 150 mcg day, D. 100 to 200 mcg day, D. 200 to 400 mcg day. 14. What factors affect the optimal replacement dose of levothyroxine? A. Age, height, and weight. B. Duration of hypothyroidism. C. Pretreatment TSH level. D. Presence of chronic illness. All of the above. 15. Which of the values represents the lower level of detection for the fourth-generation sensitive TSH assay as established by the ATA? A. 0.5 to 5 mul, 1 to 2 mul, 0.01 to 0.02 mul, D. 0.1 to 2 mul, 2.2 mul, 0.0001 to 0.0002 mul. 16. In which of the following clinical presentations should the TSH assay be used? A. Population screening for thyroid disease. B. Screening hospitalized patients. C. Patients receiving thyroid replacement after 6 to 8 weeks of therapy. D. Patients who are HIV positive. A. Screening patients with psychiatric illness. Directions for question 17. The question in this section can be correctly answered or completed by one or more of the suggested answers. Choose the answer. A if I only is correct, B. If the third only is correct, C. If I and second are correct, D. If two and the third are correct, E. If I. So, 974, Chapter 47. 17. A 62-year-old woman with a 5-year history of well-managed hypothyroidism was recently started on raloxifene 60 milligrams daily in the morning for the prevention of postmenopausal osteoporosis. Her thyroid disease had been well controlled on 150 mcg levothyroxine, Synthroid daily in the morning. Her TSH has remained within the normal range while on treatment. Her most recent TSH of 2.5 mul and normal FT4 values were noted last year. She presents today with an elevated TSH 15.5 mul after 4 months of raloxifene therapy and symptoms of hypothyroidism. What change in therapy would be best for this patient? Repeat the TSH test and FT4 tests. Increase the dose of levothyroxine to 200 mcg daily. Switch the dosing of the raloxifene to the evening. Directions for question 18. The question in this section can be correctly answered by one of the suggested answers. Choose the best answer. 18. A 69-year-old woman with hypertension and hypothyroidism is being treated for a wound infection. In the past, she was maintained on 125 mcg levothyroxine, Levoxyl, daily with a normal TSH of 2 mul. After 6 weeks of treatment with oral ciprofloxacin, 500 milligrams twice a day, she complains of fatigue and sensitivity to cold. Her serum TSH level was 14 μUL and FT4 was below normal. What is the best management for this patient? Increase the dose of levothyroxine. B. Switch the patient from Levoxyl to Synthroid. Z. Discontinue levothyroxine until the wound is healed. D. Continue therapy without any changes. Separate the administration of ciprofloxacin and levothyroxine by at least 6 HRS. Directions for question 19. The questions in this section can be correctly answered or completed by one or more of the suggested answers. Choose the answer. A. If I only is correct. B. If IV only is correct. C. If I and IV are correct. D. If I, 2, the third, and IV are correct. O. If 2, third, and V are correct. 19. Which of the following agents have been shown to interact with oral T4 replacement therapy? Itanolol, tacan calcium carbonate the third, ciprofloxacin for levothyroxine v raloxifene. 20. What is the effect of amiodarone therapy on thyroid function? A. Patients with underlying thyroid dysfunction are at an increased risk of developing hypothyroidism within 6 months of therapy. B. Patients without underlying thyroid dysfunction routinely develop subclinical hyperthyroidism with amiodarone therapy. C. Amiodarone interacts directly with circulating serum thyrotropin. D. Amiodarone has no effect on thyroid function. AB. None of the above. 21. A 33-year-old underweight woman presents to you. She is currently taking levothyroxine, Synthroid, 200 mcg daily. Her TSH level is reported to be 0.15 μUL. What would be the most appropriate change to make to her therapy? A. Continue current therapy. B. Repeat TSH. Continue levothyroxine 200 mcg daily. C. Decrease levothyroxine to 175 mcg daily and recheck TSH in 6 weeks. D. Decrease levothyroxine to 150 mcg daily. Recheck TSH in 6 weeks. E. Repeat TSH. TT4. Continue levothyroxine 200 mcg daily. 22. What is the correct formula to use for calculating TBI? I. RT through mean serum RT through. B. RT through mean serum RT through. C. TT4. RT through mean serum RT through. The T4. RT through mean serum RT through. E3. RT through mean serum RT through. Directions for question 23. The question in this section can be correctly answered or completed by one or more of the above suggested answers. Choose the answer. A. If I only is correct. B. If the third only is correct. C. If I and 2 are correct. D. If 2 and the third are correct. If I, 2 and the third are 23. Which of the following drugs are possible treatment options for primary hypothyroidism? I. Desiccated thyroid, armor thyroid, levothyroxine, Levoxyl. The third, thyroid disease 975. Questions 24 and 25 are based on the following case. AB is a 58-year-old female with a history of Graves' disease who has been suffering from severe emotion distress from a recent divorce. She began to develop heart palpitations, a fever, and delirium. She is transported to the emergency department where she admits to stopping her methimazole 2 weeks prior. 24. Which of the following disease states is most likely related to AB's clinical presentation? A. Hashimoto thyroiditis. B. Thyrotoxic crisis. C. Jod-based phenomenon. D. Factitious hyperthyroidism. E. Plummer disease. 25. Which of the following is part of the normal therapy for thyroid storm? A. Quetiapine to treat delirium. B. A blocker like lisinopril. D. PTU to inhibit the synthesis of thyroid hormones. D. Levothyroxine to help augment the negative feedback mechanism and decrease production of thyroid hormone. A. Methimazole because it is a thioamide and also prevents peripheral deiodination of T4 to T3. 26. The FDA, a black box warning for thyroid hormone replacement therapy is A. May cause life-threatening toxicity if used for weight loss. B. Risk of hepatotoxicity. C. Risk of nephrotoxicity. May cause tendon ruptures. B. May cause lactic acidosis. 1. The answer is A. C2. 5. The FTI is a mathematical interpretation of the relationship between the RRT3U and T4 levels, compared to the mean population value for RTU. The FTI is calculated using reported values for TT4 and RT3U. The normal FTI value in euthyroid patients is 5.5 to 12. 2. The answer is C, C2b. Biosynthesis of thyroid hormones begins with iodide binding to tyrosine, which forms MIT. MIT binds another iodide atom to form DIT. When MIT and DIT are formed, a coupling reaction occurs, which produces T3, T4, RT3, and other byproducts. The answer is B, C third. Hashimoto thyroiditis, chronic lymphocytic thyroiditis, is a cause of hypothyroidism. The incidence of Hashimoto thyroiditis is 1% to 2%, and it increases with age. It is more common in women than in men and more common in whites than in blacks. There may be a familial tendency. Patients with Hashimoto thyroiditis have elevated titers of antibodies to thyroglobulin. A titer 132 is seen in 85% of patients. 2 variants of Hashimoto thyroiditis have been described: gland fibrosis and idiopathic thyroid atrophy, which is most likely an extension of Hashimoto thyroiditis. 4. The answer is D and C for B. In hyperthyroid patients, remission of thyrotoxicosis is achieved with PTU by 2 mechanisms. 1. Interference of iodination of the tyrosyl residues, ultimately reducing production of T4, and 2. Inhibition of peripheral conversion of T4 to T3. Propranolol is commonly used as an adjunct to PTU for symptomatic management of hyperthyroidism. 5. The answer is E, C2. 1. The major compounds secreted by the thyroid gland after its stimulation by thyrotropin are T3 and T4. When released from the thyroid, T3 and T4 are transported by plasma proteins, namely TBG and albumin. 6. The answer is E, C third, B. 5 or 1. Graves' disease, diffuse toxic goiter, is the most common form of hyperthyroidism. It occurs most often in women in the 3rd and 4th decades of life. There is a genetic and familial predisposition. The cause is linked to an autoimmune reaction between immunoglobulin G, IgA, and the thyroid. 7. The answer is a C, the third, G3. The TS stimulation test measures thyroid tissue response to exogenous TSH. It is not commonly used to monitor thyroid replacement therapy. It may be useful in the initial diagnosis of hypothyroidism. Answers and explanations. 976, Chapter 47. 8. The answer is D, C2. 5. E. The FTI is not an exact measure of free T4, rather it is a mathematical interpretation between RT3U and serum T4 levels that estimates free T4. The correct formula used would mean that a clinician has knowledge of TT4, TABI, and estimated free T4, RT3U. 9. The answer is a C2. A2. An increase in the blood level of thyroid hormone, see circulating free T4 and free T3, signals the pituitary to stop releasing TSH. The free fraction of T4 is available to bind at the pituitary receptors. 10. The answer is B. See the third. Euthyroid patients receiving oral replacement therapy have become hypothyroid after concomitant administration of bile acid sequestrant therapy. It appears that bioavailability is reduced as a result of administering these agents at close dosing intervals. It is recommended that at least 6 HRS pass before administration of a bile acid sequestrant. It would be preferable to select another non-bile acid sequestrant when clinically possible. 11. The answer is D. C2. The free T4 in the third generation. TSHSA should be used only for the diagnosis of patients most likely to have thyroid disease based on clinical presentation and relative risk, for example, age, sex, family history, not for population screening. The third-generation TSH assay is also more commonly used to monitor replacement therapy and to minimize overtreatment and the corresponding risk of accelerated bone loss. 12. The answer is D. C2G. 3. Cost versus benefit is critical to the decision of choosing to screen entire populations, and screening for thyroid disease has been shown to not be cost-effective in the general healthy population. Screening recommendations from major medical groups has been conflicting. However, none of them recommend the routine screening of young, healthy adults.